Hello, friends of Retinal Channel Podcast. Welcome to episode 83. I'm Dr. Kayvon Kushan. I'm your host, and today's guest is Dr. Cindy Chen from University of California in San Francisco. We have a surgical article for you today, and it talks about the association of systemic methotrexate and development of proliferative vitreoretinopathy, or PVR, following detachment surgery. So Dr. Chen and her group, they looked at the repository of patients across some academic center in a system they call SOURCE. And in that system, they tried to look into see who was on methotrexate and who wasn't among patients who had vitrectomy for retinal detachment. And they have some interesting finding about not just methotrexate, but other medications that those patients were on. And Dr. Chen is a resident. She is a PGY3 resident at University of California, San Francisco. She's a Johns Hopkins grad for both undergrad and medical school. She's a rising star, and I'm very thankful to her and her preceptor who arranged this interview and answered to my request to come on the show. And without further ado, this is Dr. Chen. How are you, Cindy?
I'm good. How are you?
I'm very good. Welcome to Retinal Channel Podcast.
Thank you. Thanks for inviting me on the show.
It's a pleasure to have you. Thank you for accepting my invitation.
No worries. Pleasure to be here.
Perfect. So Dr. Chen, so as you know, well aware, this is a Retinal Channel Podcast and this is a journal club. And I was intrigued by the article that you spearheaded from UCSF on the association of systemic methotrexate and PVR formation post-retinal detachment surgery. So I thought it's a great idea to talk about it. And if you don't mind, I'm just going to give the listeners and the viewers a gist of your article, and we'll take it from there.
Of course.
So this was a retrospective study. You looked at the span of 20 years of patients who were identified as having retinal detachment. And then you looked at the association of having systemic methotrexate and other agents. And from them, a couple of them, including steroids and including azathioprine and including methotrexate, were associated with lower incidence of PVR formation. And so that's very, very interesting. Your numbers are great. You have over 2,000 eyes you're identified as having vitrectomy or retinal detachment. And you use this system called, I think, SOURCE, if I'm not mistaken. So I'm curious to learn more about it. And so this is very interesting and potentially could influence our systemic management of RD and to prevent PVR. Sounds all right?
Yeah, sounds great.
All right. So let's go over your article. What was the background? What made you and your group look into this?
Yeah, so as we know, that PVR is one of the major causes of failure of retinal reattachments after RD repair surgery. And then clinical experience and there's also a GUARD clinical trial, which is a phase 3 randomized control trial, has shown some pretty promising results with intravitreal methotrexate used. So in the GUARD clinical trial, they used intravitreal methotrexate injection weekly for patients with PVR or patients with open globe related RD, which are patients who are high risk of developing RD. And they found that in those patients who already have PVR or already very high risk for PVR, they found this weekly injection of intravitreal methotrexate resulted in an improved rate of retinal reattachment.
Yes.
And then our group actually have a prior proteomic study on baseline vitreous cytokines in patients undergoing primary RD repair. And then we actually found that in patients who underwent primary RD repair and those who later developed PVR, they actually had elevated levels of several relevant pro-inflammatory proteins in their vitreous at baseline, even at the time of the primary RD. So we were thinking that maybe those patients who are already at risk, the protein biomarkers indicative of PVR might already be present at the initial event of RD. So this finding could allow early identification of patients at risk for subsequent PVR development. So I guess next step is that if we had a prophylactic treatment to offer to those patients at risk, that it might reduce the subsequent development of clinical PVR. So as a step toward determining whether systemic methotrexate treatment could be a candidate therapy for these patients, we propose to evaluate the rate of PVR in patients who are already on methotrexate, systemic methotrexate, at the time of primary RD repair for other reasons, for example, cancer or systemic autoimmune disease. And then we studied the rate of PVR development in control compared with patients not taking systemic methotrexate at a time of primary RD, and see if there's a difference in the rate of PVR development. And then, even though it's a retrospective study, it's a retrospective cohort study, we did find this actually almost half the risk of developing PVR in patients who were on systemic methotrexate for other reasons.
Yes, that's very interesting. So just to recap, your proteomic study in your institution, you showed someone with a fresh RD already may have higher levels of pro-inflammatory cytokines in the vitreous cavity or aqueous humor. And everyone was like that, or some people were like that?
I think that on average, patients who develop PVR later actually had those patients had higher levels of those pro-inflammatory proteins and cytokines in their vitreous at baseline compared to patients not developing PVR later on average.
I'm very curious to read that article as well. Sounds fascinating. Okay, so in this published article in Ophthalmology Retina, you just published this right off the press, you used a system called Source to find your charts across multiple institutions. And from 2004 to 2024. Could you tell us about Source, please? I mean, it sounds like Iris in a way, but can you tell us how it works?
Yeah, of course. Yeah, so it's a pretty exciting collaborative repository of data. So it's called, I think the full name is Site Outcomes Research Collaborative Source. So it's managed by the University of Michigan, but there are 14 academic centers they're currently participating in this database. And then you mentioned Iris, and Iris have database data from both academic centers as well as private practice. Versus Source right now is mainly academic data from academic centers. I think that's very important for our study because, first of all, the population we're looking at is very complex. We want to look at patients who had RD and also on systemic methotrexate, and also we're looking at if they develop PVR, which some patients might be referred to academic centers for the management of this more complex condition. So it's actually perfect for our study. And then because the large number of patients in the system, we're able to find this unique cohort of patients that we're interested in.
And I noticed you use two different ways of identifying PVR because there's no ICD code for proliferative vitreoretinopathy. So you went around it and you kind of use different codes in two different ways. Could you tell us about your way of identifying PVR?
Yeah, of course. As you mentioned, there's no ICD code that exactly corresponds to the term proliferative vitreoretinopathy. So we use the ICD codes that's referred to other non-diabetic proliferative retinopathy, or codes that's referred to tractional RD to identify PVR. And we did exclude patients who had a history of PVR or history of PDR or serious RD or retinal dialysis or ocular trauma, so that we can make sure that these patients actually have PVR that we're interested in. And then we chose those ICD codes not only because of that reason, but also these ICD codes have been used to identify PVR in a prior nationwide database study, in which proved to be pretty successful in identifying those patients. And because we want to be sure that we did identify those patients, we did do a sensitivity analysis. Basically, we tried an alternative way of identifying patients with PVR by using CPT codes of complicated surgical repair in the same eye within 6 months from the index RD instead of using the ICD codes. And we found that none of the patients on methotrexate, on systemic methotrexate, develop PVR identified by the CPT code of complex RD surgical RD repair using these methods, versus there's a lot of patients who are not on systemic methotrexate had PVR identified by CPT method.
Mm-hmm, mm-hmm. And of course, to identify your original retinal detachment, that's a simple code for ICD code, rhegmatogenous retinal detachment. That's how you identified, I think, over 2,400 cases of people who had retinal detachment.
Correct. And then to make sure they are rhegmatogenous instead of like serous RD, which could be prevalent in patients with uveitis related to systemic methotrexate use, we did also require not only a ICD code for RD, but also a CPT code for RD repair within 14 days of the ICT code for the index RD.
And the way of repairing those RDs, which were like, I think I'm just reading number 2,674. They all had repair, so they corresponded to the repair procedure, and that was essentially majority was vitrectomy, but you also had some pneumatics and some buckles, so they all had repair done based on the code you correlated. Okay, and then of them, 1.8% of everyone, all comers of detachment with the repair, they were on systemic methotrexate. And then you said of those 1.8%, which is essentially 48 patients, you compared the incidence of PVR, which was, I guess, just 4.2% for those on methotrexate versus 9.2% for non-methotrexate eyes. So it's essentially slashes into less than half.
Yeah, that's pretty interesting finding.
Yeah. And how about you? You have smaller numbers for other things, for like azathioprine, or but bigger number for steroids. But your focus in the article has been on methotrexate. What about those other things? Steroid sounds like an easier target, easier molecule. Or can you talk about that, please?
Yeah, of course. So methotrexate, as we know, is an anti-metabolite. And we're interested in if methotrexate works, we're also interested in if other anti-metabolites in the same class of medications do they work as well. And we did find that systemic azathioprine use is associated with the lower risk of developing PVR. However, we didn't see that in mycophenolate, which should have a similar mechanism. It is possible that even though they're in the same class, they might not work exact the same way. So it is possible that mycophenolate is not less effective, but it is also possible that there's some other residual confounding factors that cause a discrepancy in the how mycophenolate behaved in the study. And then
plus numbers were pretty small for mycophenolate, right? It was very small numbers.
Yeah, correct. The number is small. And then we did include steroids in this study. And then we actually included systemic steroid, as more of a positive control for our study. As you know, in our study, we had some negative controls like metoprolol, which we wouldn't expect to be have any effect on PVR as negative controls. And systemic steroids have been found in a couple prior studies to be associated with a better rate of retinal reattachment and lower rate of PVR in patients. So in this study, and because of systemic steroids is so common in patient population, we did include that as a positive control. So that's we want to, if steroids turns out in our study to have a lower rate of PVR, then we're more confident that our finding is true.
Okay, so you assume that's a given, and your number is pretty big for steroid. You had 564 patients on systemic steroid out of 2,600. So that's a very significant number, and definitely it was a strong protective effect of systemic steroid and PVR formation.
Yeah.
Okay, but then you saw you had other things, amlodipine, metoprolol, or Lipitor, those other random things, and none of them were influential, which makes sense. Those are your controls. That's smart. Good. Okay. So what do you recommend? Should people be on systemic methotrexate when they have retinal detachment now, or systemic steroids? What do you recommend based on your study? Or do you still need to study more prospectively?
Yeah, that's a good question. So as you know, this is a retrospective cohort study, multi-center, and we did found that systemic methotrexate use in patients at the time of or prior to primary RD or systemic azathioprine was associated with a reduced risk of developing PVR within the 6 months after the primary RD. And so it is very promising. So we're trying to find a drug that could prophylactically be used as prophylaxis against PVR development. And I think this study does show that systemic methotrexate and other antimetabolites like azathioprine could be pretty promising candidates for this. But I do agree that more prospective trials will be important to more definitively determine if we give patients either randomized or prospectively give patients this antimetabolite therapy, would they have reduced risk developing PVR. And I think this would be especially exciting if we, at a time of primary RD, if we could look at the vitreous and see if they have any inflammatory markers. And
Yes.
if we found that in certain populations that elevated levels of pro-inflammatory proteins in the vitreous, we know that they're higher risk of developing PVR. We could maybe target those populations more, and then those patients more likely to benefit more from the systemic methotrexate therapy. Because of course, any medications have side effects. So if we have the benefit of those patients just more, then we might be looking at doing this therapy in those high risk patients.
Yeah, that makes sense. If you only use it for high risk patients, that would be quite beneficial for them. I agree with that. Were you able to look at the duration of methotrexate use, or how long during the course of the study they were on it, or what dose or route of delivery they were on it?
Yeah, that's actually quite challenging. We did make sure that the systemic methotrexate use was on the day of the primary RD, or at least those patients have used systemic methotrexate before the index date of the primary RD. But because the medication's dosage was not available in every patient, so it's hard to study in this big database. And I think that those academic centers, patients go to a eye doctor appointments, they would be prompted to enter their medications, but the dosing information and how long when exactly they started might not be available. And I think that Dr. Josh Stein, the chief manager of Source database, they have been looking at his team has been looking at some natural language processing to look at some clinic notes in some certain conditions. But I think that if that gets developed more, we might be able to glean more information from clinic notes from other specialties or the primary care doctors for those patients, because there's a big population, 2,000 patients. I think if we can have natural language processing to extract those kind of data, that would be more beneficial as well.
Yeah, but that's the start. What you have is a good start. Wonderful. Anything else we missed, Dr. Chen, you want us to remember from your study?
I think we think we covered pretty much very well about the different aspects of study, and I think that PVR is very a common risk for retinal detachment repair failure, and I think that's our paper and study offers in a direction that we can further study to determine if there's anything we can offer patients at the onset of primary RD to prevent the headaches downstreams.
Yeah, PVR is a bane of our existence, that's why most detachments fail. Very well. Well, congratulations for publishing this excellent work and looking at this study. It's definitely is valuable, adds to our knowledge about how to really tackle PVR. And I wish you all the best in the next phases of your career. And thank you for coming to Retina Channel podcast.
No problem. Thank you for having me.
Great. Have a good night.
You too. Take care.
Bye.
Well, folks, this wraps up episode 83 of the Retina Channel podcast. Thank you for joining us, and thank you, Dr. Cindy Chen, for coming to the show and nicely explaining her group's work on the association of methotrexate and PVR formation. Well, some heads up about our next episode. Dr. Rajiv Mooney from St. Michael's Hospital at University of Toronto will join us again, and he'll be talking about two recent articles fresh off the press of his group's work on retinal detachment, and one of them is an offshoot of the PIVOT trial. Well, until that episode, you folks take care, be well.